This topic was also suggested to some extent by Dr. Bang, and I also wanted to talk about clinical cardiology because people thought that as the imaging and more of the evidence emerges for investigative cardiology, probably clinical medicine is dying. But that's not the case, and in my oration, I'll take you through and I'll talk about why I feel that evidence-based clinical medicine is not only emerging, but it's going to pay a big milestone to come in future as well. There have been days when people used to remember these photographs and the first echocardiographic machine or the first stethoscope emerging. The science has changed over time, but before I proceed to tell you how clinical evaluation can give you non-invasively the invasive hemodynamics and how the science is emerging all across the world, I would first like to show you the normal hemodynamics that we all are clinically aware of. The RA pressure, the peak systolic PA pressures, the wedge pressure, and systemic vascular resistance are pretty much the evidence-based evaluation that's the focus of emerging new clinical examination technologies. In my points of evaluation, I'm going to touch upon in this oration about these clinical points. And I will touch briefly in this topic what is known classically and what is the update. We will touch upon symptoms and hemodynamics, which is known, and we'll touch upon bendopnea, which is the new emerging sign. I'll also take you through the pulse characteristic and how two kinds of pulse can exist even in one individual. We'll also look at blood pressure and the concept of proportional pressure, which is known, but how augmentation index, pulse wave velocity, and CAVI are emerging as the new pressure or pulse hemodynamics that need further evaluation for hemodynamic correlation. We'll also look at JVP, which is not only for passing medical exams, but also has an important waveform with emergence of new clinical signs like anthem sign. Heart failure and hemodynamics, heart sounds, and of course the A2OS interval and how they have been further worked upon, and assess the clinical evidence-based assessment of valves will also be touched upon. I'll also take some evidences for the dynamic auscultation and Valsalva, and the ABI, how it's been changing to what is now TBI. Pulse oximetry in the COVID era has taught us a lot about perfusion index, and cardiac output in SVR and more is yet to emerge, which probably I will not be able to do justice in the time that I have. Coming to the symptomatology, and this is a classical reading that we all did and we all remember, how the functional class correlated with the wedge pressure. If you had a patient who presented to you with a paroxysmal nocturnal dyspnea, we always thought that his wedge was between 18 to 25, and his probably pathology was an interstitial edema, which would look like a curly B lines on chest X-ray. This would be added of 5 millimeters of mercury for looking at if the disease was chronic. So if you had a patient based on NYHA class, you can predict history-wise what is his likely wedge pressure. If you add acute versus chronicity, you just had to sum it up. And this was evidence-based by a lot of cath invasive studies by Perloff et al. And has been published and known in medical literature. But what is updated now is bendopnea. People have published recently in PAH patients as well as in patients with heart failure. In patients with pulmonary arterial hypertension, 1/3 of the patients actually reported bendopnea, suggesting it's not just venous congestion, but it's got more to do with wedge itself. These patients hemodynamically had higher RA pressure, pulmonary vascular resistance, RV end diastolic dimension, and lower TAPSE. And this was all statistically significant. Bendopnea patients also had lower 6-minute walk test and higher NT-proBNP. 28% of the patients recently evaluated for congestive heart failure associated bendopnea were found to have bendopnea within 8 seconds of bending, not the classically known 30 seconds. This also correlated with a higher mean RA pressure and wedge pressure, which increases on bending, but the cardiac output does not change. This threefold higher supine hemodynamic profile consisted of higher wedge and lower cardiac indices was documented in patients with heart failure. It goes on to tell you that bendopnea is not only a sign of early heart failure, but it is also predictive of RA pressure and the wedge pressures. Arterial pulse has often been studied in the various waveforms, and we know what are the classical waveforms that people have learned of. Now there are emerging evidences on how these pulses correlate with various hemodynamic parameters. Anacrotic pulse would usually suggest a peak gradient more than 70. A bisvariance, which of course is understood to have higher amount of AR than presence of aortic stenosis. Corrigan pulse if is palpable, usually means that the pulse pressure is more than systolic blood pressure by the ratio is more than 0.5. Suction wave is the new wave which has now been talked about, and with the wave intensity analysis and it being a systolic phenomena, hence the water hammer characteristic as a distal diastolic runoff does not explain the pulse characteristic, which I will touch upon as I proceed. Diacritic notch, if it is more than 50% in the pulse pressure, that's when usually a clinically palpable diacritic wave is appreciated. It also rules out if the blood pressure is more than 130, the likelihood of diacritic pulse being palpable is pretty unusual. Parvus et tardus correlates with an aortic valve area less than 1 centimeter square, while alternance is predictive of ejection fraction less than 30%. Pulsus paradoxus is best felt in brachial with 15 millimeters, but there are now evidences with a sensitivity of 98% and specificity of 83% that a more than 12 millimeter of paradoxus pulse would suggest a predicting a tamponade that can ensue. The update has been the wave intensity analysis. Corrigan, when he talked about rapid arterial emptying in diastole due to regurgitation of LV, has not been proven to be correct because it showed a sudden narrowed peak in the early systole, and hence this waveform phenomena is more of a systolic pulse. This was further documented by Chirinos in a patient who showed two kinds of pulse in a single patient by invasive assessment. The radial pulse was water hammered, but carotid pulse was bispherians. And this has been now further evaluated to show that there is sudden radial pulse descent after the initial pulse peak, which results in the water hammer characteristics. And hence the way we understood water hammer is no more the diastolic phenomena, but a systolic phenomena. Assessment of pulses can also tell you about the asymptomatic femoral bruit being a finding of atherosclerosis. An abnormal pulse oximetry between two limbs, if just a saturation difference is more than 2%, would show that it's comparable to ABPI for assessment of lower extremity PAD with likelihood ratio of more than 30% in a paper by Khan et al. Published in JAMA. Blood pressure assessment, of course, apart from the white coat and masked hypertension, which was published in India Heart study, where they looked out that the white coat hypertension continues to be prevalent by 16 to 80% and masked hypertension 9 to 15. And hence 1/3 of the hypertensive patients in the office readings are falsely classified as either normotensive or hypertensive. Orthostasis, of course, remains a big challenge as our population ages. But what is new is the proportional pulse pressure correlated by Stevenson and Perloff. If the proportional pulse pressure, which is the pulse pressure divided by systolic blood pressure multiplied by 100, is less than 25%, then usually the cardiac index is less than 2.2. Pulse pressure, if it's more than 25%, in 83% of the patient, it correlated with cardiac index of more than 2.2. People have also looked at circulation time, which is the nothing but simple bedside assessment of looking at the time at which the nadir of pulse oximetry happens when the patient is holding the breath. If this time is more than 34 seconds, then means that the cardiac output is less than 4. This has been documented with a sensitivity of 91% and specificity of 83% by Perloff and Stevenson. The new emerging assessment of blood pressure is also talking about augmentation index. Lot of now blood pressure machines actually give you the value of blood pressure assessment along with the augmentation. Central augmentation is nothing but the ratio of augmentation pressure, which is nothing but the reflected waves coming back and augmenting the peripheral pressure because of peripheral vascular resistance. And hence the pressure that you measure at the periphery also tells you status of the peripheral arterial bed as well as systemic vascular resistance. Peripheral augmentation and central augmentation are two aspects of it. This can also be further quantified by what is called as boroionometry, which is reflective of dP by dt, the rate of change of pressure with time in the wave form. This is one of the report how it looks like, where you can actually look at the blood pressure. This is one machine that I have at my own clinic. And this machine we have used to publish this in Indian Heart Journal, where we were able to correlate that augmentation index and pulse rate variability were present to be higher in CAD patients as compared to counterparts of healthy. The left ventricular contractility as assessed by dP by dt or the borioionometry was also lower in patients if they had coronary artery disease. Hence, just looking at blood pressure, you can predict whether the patient is harboring a silent CAD underlying or not. In our study, AI by BP plus machine emerged as the strongest predictor for prediction of CAD amongst the blood pressure parameters. The highest odds were also found across the gender, whether the patients were male or female. The update is about pulse wave velocity. As the wave travels from the center to the periphery, the resistance that it encounters and the distance it measures over time can also help you to pick up whether vessels are stiff or not. Increase in the blood pressure, heart rate, and systemic vascular resistance will increase the pulse wave velocity. The changes in cardiac output do not impact it. So you may have normal cardiac output, but may have higher peripheral vascular resistance, translating into a pulse wave velocity reflected into it. This holds true for the lower blood pressure range as well as the medium blood pressure range with the correlation of systemic vascular resistance. This would help you to titrate whether you want to give ACE or ARB or vasodilator more if the patient has got higher systemic vascular resistance, whether he be a patient of heart failure or simple hypertension. TAVI is emerging as a principle for stiffness parameter, and this has been used to correlate with left ventricular hypertrophy, CAD, and stroke. These all can be measured non-invasively, just like blood pressure assessment, and can tell you about the associated atherosclerosis, and these are the values of normal cutoffs for both the gender across the age group. Valsalva maneuver has often been taught in medical college, but it's been never used in practice. But we have good amount of evidence to tell us that absent of overshoot phenomena would tell you that the patient's ejection fraction is less than 40%. Of course, the other three reasons where the overshoot will be lost will be mitral stenosis, because the stenosed valve will not allow more cardiac output to return, blood to return to the LV to increase the blood flow across the cardiac systole, or ASD, where the respiratory changes with the Valsalva changes would be compensated by a shunt across the defect. Even constriction because of ventricular interdependence phenomena will not allow the overshoot response to take place. The square root response also tells you about the elevated filling pressure, and this is now being quantified by pulse amplitude ratio, which is the minimum pulse pressure at the end of the Valsalva strain phase against the maximum pulse pressure at the onset of strain phase. This ratio is consistent with square wave and hence can predict a presence of elevated filling pressures, that is elevated RA pressure. So what is known is that RA or the JVP is not just reflection of right heart, it also predicts the left heart. It is a method by May's sign or Gartner's sign that we was classically taught about, that you just ask the patient to raise the hand, and the hands wane as they collapse. You would know what estimated pressures you're dealing with on the central venous side. Also, the undersurface of the tongue, if you could see, the veins are engorged, means the patient's venous pressures are high. So this was classical old test studies, but they were never correlated hemodynamically. But now, we now know that you can look at, which was being documented by Razkala as the anthem sign, which begins like the classical venous collapse method, where the patient is lying with 30-degree elevated supine position and ask the patient to raise his hand to keep it on chest. If the veins become collapsed as he raises the hand, CVP is likely to be low or normal, but if they remain elevated, then it means the central venous pressures are high. This anthem sign has been shown to have specificity as good as 85 versus 57% rather than assessing the just JVP, and hence people are talking about this sign to be incorporated in clinical evaluation rather than just looking at JVP. More importantly, Kusamal sign also picks up elevated PVR, effective electrical resistance, reduced peak and exercise cardiac output, and ventilatory efficiency. This is one of the studies where they've looked at the pulmonary hemodynamics and right heart diastolic metrics, and how the Kusamal sign could predict it much better, whether it be mean RA pressure, PA pressure, compliance, or wedge pressure. Abdominal jugular reflux, or reflux as it is called, it's said to be positive if there is rise of more than 3 centimeter and sustained for more than 15 seconds on abdominal compression of 10 seconds. Positive abdominal jugular reflex would correlate with a pulmonary arterial wedge of 15, and hence the right heart does not always mention right. The JVP also correlates with the wedge pressures on the left. It's said to be strong predictor with likelihood ratio of 6 for heart failure, and wedge being more than 15 is easily estimated. This is also derived from the ESCAPE trial, where PA systolic pressure can be predicted by PA wedge. PA systolic is twice the PA wedge in ESCAPE trial. If the RA pressure was more than 12 and their patient had 2 pillow orthopnea, this was correlating with a PA wedge of more than 22. So history can tell you what wedge you're dealing with. Positive predictive value of RA more than 10 correlated with a wedge pressure of more than 22 in 88% of the patients in ESCAPE trial. In SOLVE trial, JVP distension was predictor of heart failure hospitalization with hazards of 32%, death from pump failure by 37% higher, and either of the two by 30%. Abdominal-jugular reflex, as I said, was predictive of wedge more than 15. Presence of jugular venous distension, either at rest or induced at bedside, had very good sensitivity and specificity. Yes. RA pressure, heart failure is pretty much known predictor, and also you can pick up from the heart sounds by where you hear the P2. If the P2 is heard at the base, it's 35, it's away, then it goes up to 75. S3 correlates with EF less than 50, end diastolic more than 15 to 25, BNP more than 100, while S4 correlates by more than 50% and LVDP more than 15. Wells index, which is QS1 interval versus as compared to A2OS, was better predictor of valve area less than 1.2. Paradoxical second heart sound, palpable S4, predicts a gradient more than 70, while reduced carotid pulse suggests an aortic valve area less than 1. Peripheral signs of AR have also been evaluated by CAVI, especially the rapid distal runoff of Hill's sign, and the diastolic components is better heard when compression by distal, which is the Dorosius murmur, has also been correlated hemodynamically with the effective regurgitant orifice with AR. Right-sided events with respiratory increase have 100% sensitivity on dynamic auscultation. Squatting has been quantified to be 95% sensitive, while rapid standing also has 95% sensitivity, with Valsalva actually being more specific than sensitive. ABPI and TBI have now been integrated in assessment of limb, and ABI alone is not a good predictor. In a patient whose ABI is between 0.9 and 1.3, a TBI is a better predictor of limb ischemia or major limb events. This is also a predictor of coronary artery disease with a higher sensitivity and specificity, and ABI-TBI in CKD is also a predictor of mortality. Pulse oximetry has now become a day-to-day availability after COVID, and what you see here is the PI, which is perfusion index, which is ratio of pulsatility of blood flow to non-pulsatile with PI 0.2. So cardiac output can be correlated by Forrester Diamond classification, and the cardiac output of the 2-minute assessment of hemodynamics is by a good clinician, good parameter of assessing the same. Cardiac power and future lies in lot of other things amazing like PA pulsatility, capacitance, inotropy, and SVR. Science like soul never dies. It transforms its manifestation from baseline ECGs to wearable technologies. Thank you for patient hearing, and these are my references.